A 62-year-old construction worker in Brazil wakes up one morning and cannot get out of bed. Not because he is lazy. Not because he is sick with a fever or a virus. He simply cannot move his right hip without a pain so sharp it takes his breath away. He has felt it building for 3 years. He ignored it because he had no choice. Work or starve. That was the math. He goes to a clinic. The doctor looks at his X-ray and says 4 words. You need a hip replacement. The man asks how much. The doctor says the equivalent of 18 months of his salary. The man goes home. He stops working. 6 months later, he cannot walk to the kitchen without holding the wall. This story is not rare. It is not even unusual. It is happening right now, in some version, to approximately 320 million people worldwide living with hip joint disease. 320 million. That is the population of the United States. Walking around, or trying to, with a joint that is grinding itself into dust. And the global medical system, for all its technology and trillion-dollar infrastructure, is reaching that population unevenly, expensively, and in many cases, not at all. So let us talk about what is actually happening inside that joint. Because understanding the biology is what makes the global crisis make sense. The hip is one of the most elegant mechanical structures in the human body. A ball and socket joint where the top of your femur, your thigh bone, fits into a cup-shaped socket in your pelvis. The entire thing is lined with articular cartilage, a smooth, slippery tissue that allows the joint to move with almost zero friction for decades. The problem is that cartilage does not regenerate. Once it is gone, it is gone. Hip osteoarthritis is the gradual destruction of that cartilage. Bone begins grinding against bone. The joint inflames. Bone spurs form. Movement becomes painful, then limited, then eventually impossible. It is not dramatic. It is slow. It is relentless. And it affects an estimated 528 million people globally when you include all forms of degenerative joint disease. What causes it? Age is the largest factor. After 50, the risk increases sharply. But age alone does not explain the scale of what we are seeing. Obesity is accelerating the crisis. Every pound of body weight adds roughly 4 pounds of pressure on the hip joint. The global obesity rate has tripled since 1975. The correlation with rising hip joint deterioration rates is not coincidental. Physically demanding labor is another driver. Construction workers, farmers, factory workers, people who spend decades loading their hips with repetitive stress and heavy weight. These are also, not coincidentally, the people with the least access to early intervention and treatment. Then there is the genetic component. Certain structural abnormalities in the hip, conditions like hip dysplasia or femoroacetabular impingement, accelerate cartilage breakdown even in young, active people. Athletes in their 30s. People who did everything right and still find themselves facing a joint that is failing ahead of schedule. The global distribution of hip joint problems maps almost perfectly onto inequality. Wealthy countries diagnose early, treat aggressively, and replace joints routinely. Lower-income countries diagnose late, treat inadequately, and replace almost never. In the United States, over 500,000 hip replacement surgeries are performed every year. In all of sub-Saharan Africa, the number is in the low thousands. Same disease. Wildly different outcomes. And the gap is not closing. It is widening. That is part 1. The biology and the inequality are both clear. In part 2, we follow the money, the medicine, and the mechanism that determines who gets to walk without pain and who does not.
The total hip replacement procedure has existed in its modern form since 1962. A British surgeon named John Charnley developed the technique. Low-friction metal, and plastic components. Bone cement to secure them. Decades of refinement followed. Today, a well-performed hip arthroplasty has a success rate above 95%. Most patients report life-changing improvement within 3 months. The surgery works reliably, consistently, across populations and geographies. The problem is not the medicine. The problem is the mathematics of access. In the United States, the average cost of a total hip replacement without insurance is between $30,000 and $45,000. With insurance, the out-of-pocket cost varies wildly. Some patients pay $2,000. Some pay $12,000. Depends entirely on the plan, the hospital, and the negotiated rates that the patient has no visibility into before signing the consent form. In the United Kingdom, the NHS performs the surgery free at the point of care. The waiting list, however, can stretch to 2 years. 2 years of deteriorating cartilage, increasing pain, decreasing mobility, muscle atrophy, and the psychological weight of knowing the fix exists and you are simply waiting your turn. In India, a hip replacement surgery in a private hospital costs between $4,000 and $8,000. Still unreachable for the majority of the population. Government hospitals offer subsidized procedures but with waiting periods, supply shortages, and inconsistent implant quality. In Nigeria, Ghana, Bangladesh, and most of Southeast Asia, the infrastructure for joint replacement barely exists at all. Orthopedic surgeons are scarce. Implants are expensive and often unavailable. Rehabilitation facilities are nearly non-existent. So hundreds of millions of people are living with a condition that has a known, proven, reliable solution. And the solution is simply not available to them. Not because the science failed. Because the system was never designed to reach them. Now here is where the global orthopedic implant market becomes its own uncomfortable story. The hip implant industry is worth approximately $20 billion globally and growing at roughly 5% per year. 5 companies, Zimmer Biomet, Stryker, Dupuis Synthes, Smith & Nephew, and Wright Medical, control the overwhelming majority of global implant sales. These companies sell the same implant for dramatically different prices depending on the country, the hospital system, and the purchasing power of the buyer. An implant sold in Germany for $3,000 may reach a private clinic in Pakistan for $8,000, after passing through multiple layers of distributors, each taking a margin. The patient at the end of that chain pays for every layer. And most patients have no idea the chain exists. Non-surgical treatment options do exist and are critically important for the hundreds of millions who cannot access surgery. Physiotherapy, weight management, anti-inflammatory medication, corticosteroid injections, and newer interventions like platelet-rich plasma therapy and hyaluronic acid injections can slow progression and manage pain. But they do not reverse cartilage loss. They manage decline. They buy time. Researchers are working on cartilage regeneration therapies, stem cell approaches, biologic scaffolds. Some early results are genuinely promising. But clinical translation is years away for most, and the cost trajectory of those innovations suggests they will reach wealthy patients first. Again, the pattern repeats itself across every layer of this crisis. The biology does not discriminate. The system does. 320 million people. A proven surgical solution. A global industry generating $20 billion annually from that suffering. And a distribution of access that follows the map of global inequality with almost mathematical precision. So the question that the science cannot answer, the one that the implant companies and the health ministries and the insurance actuaries are all quietly, carefully avoiding, is this. At what point does a preventable disability, affecting hundreds of millions of people, with a known cure, distributed according to wealth rather than need, stop being a medical problem and start being a moral one? And more practically, who decided